All right. Well, I will get started as people keep trickling in. Just a reminder that this session is being recorded. So if you have concerns about that, you can keep your camera off. But we do record these and post them onto our Transforming Communities Institute YouTube channel so that they can be viewed at a later date. My name is Teresa Larson. If you have been at these sessions previously, hopefully I'm a familiar face, but I am a researcher for the Transforming Communities Institute. This continuing education session is being provided in collaboration with the USU Social Work Department, and we do these monthly. So if you enjoyed today's session, or if you want to see what's happening in the future, make sure that you stay connected with us through our email, listserv, or on social media, which I will share at the end. And before we get started, I will provide the Utah State University land acknowledgement, which is that as a land-grant institution, Utah State University campuses and centers reside and operate on the territories of the 8 tribes of Utah, who have been living, working, and residing on this land from time immemorial. These tribes are the Confederated Tribes of the Goshute Indians, Navajo Nation, Ute Indian Tribe, Northwestern Band of Shoshone, Paiute Indian Tribe of Utah, San Juan Southern Paiute, Skull Valley Band of Goshute, and White Mesa Band of the Ute Mountain Ute. We acknowledge these lands carry the stories of these nations and their struggles for survival and identity. We recognize elders past and present as peoples who have cared for and continue to care for the land. In offering this land acknowledgement, we affirm Indigenous self-governance history, experiences, and resiliency of the Native people who are still here today. Just as a reminder, I said it previously, but please ensure that your Zoom name matches whatever name you would like on a continuing education certificate. If you need help with that, please let me know. To receive continuing education credits for this session, you must stay for the entire session and complete the follow-up survey that I will send out after the presentation. And then the certificates are sent via email. If you have any questions during the session, I do keep an eye on the chat, but I am the technical facilitator, so if it's technical issues that you're facing, I'm the person to talk to. And if it's questions for Dorothy about the session, just wait for those opportunities as she presents them. Now I will do a quick introduction of Dorothy, who is our presenter today. So Dr. Dorothy Wallace has worked in community mental health and substance abuse treatment since the beginning of her social work career. She has worked and had experience as an admissions director and a case manager for nonprofit agencies, has worked with individuals living with substance use and mental health diagnoses, and helped them to seek access to affordable and available treatments. These experiences have led her to engage in research around access to mental health care, substance use intervention, substance use in rural communities, and efficacy of recovery courts. And Dr. Wallace is also a faculty member in the Utah State University Social Work Department. So we thank her for joining us today and providing this training. And the time is now yours, Dorothy.
Great. Thank you so much, Teresa. I really appreciate it. So today we are going to be focusing on overcoming barriers to substance use treatment and kind of going over what those barriers are. So as Teresa mentioned, my practice experience is really rooted in community mental health care, but mostly substance use care. And so before I went back to school to work on my PhD, I was an admissions director for a block grant funded treatment facility in Nashville, Tennessee. And those experiences are what really opened up my eyes to the immense barriers and immense hurdles facing individuals living with substance use disorders and substance misuse as they navigate the treatment system. So we were one of really 3 places that were mainly block grant funded and had people travel 8 hours sometimes to come to our facility because there just weren't other options. And I know I've only been in Utah about a year and a half, but I know based on my experiences here so far that that's not an uncommon story as well. So with that being said, I will go ahead and share my screen and we will get started. So a little overview of today. So we're going to start off by talking about substance use statistics in the US and Utah, why treatment is important. And then I'm going to go into a little bit of my research, which uses a different model called the Gelberg-Anderson model for vulnerable populations on factors that contribute to someone seeking treatment. And then finally, we're going to come together to talk about overcoming barriers to treatment and next steps for social workers. So substance use, misuse, and abuse is prevalent throughout the US. I teach a substance use elective here in our programs at USU. And I tell students, even those who aren't interested in specifically working in substance use populations, that no matter what field of social work you go into, you're likely to interact with individuals who maybe have some form of problematic substance use. I know that's true when I think about my friends that I graduated with my BSW and MSW with, even if this was not not the field that they wanted to go directly into, those that worked in child welfare, those that worked in hospice, those that work in medical social work, in every kind of smaller field that we go into, we have potential to interact with someone dealing with substance misuse. And that's because it's one of those things that is not discriminatory. While there are certain risk factors like adverse childhood experience, it can impact anyone regardless of their age, their race, their socioeconomic status, really any point of intersectionality. So when we're talking, I'm going to primarily talk about problematic substance misuse today, and we do have specific DSM criteria to diagnose a substance use disorder, but any illicit substance use can be considered potentially problematic due to the illegality throughout the US. What's really staggering here is the gap between treatment needs and how many people seek treatment. So you can see these statistics from 2022. They actually just came out this month. The National Survey on Drug Use and Health is conducted every year, which is how we get a lot of this information. So 26% of adults over 18 reported past year illicit substance use, with 9.1% of those using illicit substances other than cannabis. 18.1 met the criteria for a substance use disorder, so either illicit substances or alcohol, but only 4.6% of those individuals received treatment, and 4.5% of those individuals thought that they should get treatment, but they did not seek it. Utah is not exempt from having individuals who live here who experience substance use disorders. Between June of 2022 and 2023, 683 Utahns died of a drug-related overdose. This is more than the car accidents that occurred in the state. And this is unfortunately a 7.73% increase from the year prior. And this is in a time when drug overdose deaths have decreased nationwide by about 0.6%. So not a huge decrease, not as much as we would like to see, but it is going in the wrong direction here in Utah. In 2018, a study found that 80% of heroin users in Utah started with prescription opioids. And again, that is something that is pretty common nationwide. So when we talk about treatment is a really broad term, and treatment for substance misuse is often defined very broadly. So it can include a 1 hour a week outpatient service, a 9 hour a week intensive outpatient, partial hospitalization, residential treatment, and detox. It can include medication management utilizing tools such as buprenorphine or naltrexone. It can also include self-help groups and sober supports like 12-step programs and others. We also don't want to forget our sober living environments that provide a valuable resource. for many people, this treatment is really a continuum. For individuals who report misusing alcohol, opioids, or benzodiazepine, treatment often begins with detox and then steps into those lower levels of care. And our goal is to keep people in the least restrictive method of care and keep people engaged in treatment as long as possible. Treatment can include a lot of those combinations. It's not uncommon to have somebody who attends intensive outpatient programming while also being engaged with a medically assisted treatment program. And it's really not a one size fits all approach. So I really wish it was. It would be so nice if we just had a like magic button that we pressed and it was absolutely like, I know that this treatment will work for every single person every time. And that's not really always the case. But I often tell people that my goal as a social worker is to work myself out of a job where I am no longer needed, right? That would be the goal, that people are thriving and don't need us. But until that happens, we're there and hopefully able to help them overcome some of these barriers. So you might be wondering why substance use treatment, right? Ours, is it really effective? Is it really something that people need? And again, things are so individualized that I'm not going to speak in too broad of terms, but really there are a lot of benefits to treatment attendance. So the main goal of substance use treatment is to promote abstinence or reduction of substance use. Substance use really alters those brain pathways and can alter our dopamine functioning. So someone, when they begin to use to get high, they feel those euphoric effects. That's how most substance use begins, is the really euphoric. It feels really good. And then after a period of time, you're using it to feel normal. And then even after a period of longer time, you have a new normal that is well below what your formal baseline was. A powerful thing about substance use treatment and about abstinence and about reduction of use is that when the brain begins to heal and a person can feel those natural senses of dopamine again. When people reduce or stop their use, they're preventing greater burden of disease and eventually preventing death, which cannot go unstated enough. But treatment is not just about the cessation or reduction of use. There's a lot of positive outcomes for people who engage with treatment and complete a treatment program. So when people attend treatment, they report better relationships with their family and friends. They report improvement in the workplace and a reduction in legal problems. Society-wide benefits, treatment costs less than a lot of our current models, which include, unfortunately, include incarceration. And additionally, it providing treatment strengthens perceptions in the community. People, when they see individuals going to treatment as opposed to being incarcerated related to substance use, there's kind of this mindset shift where people begin to see like, oh, this is something that can be treated and needs to be treated. And last but certainly not least, treatment improves individual self-esteem, and it also allows for treatment of co-occurring psychological disorders, which is often very necessary in achieving that long-term sobriety. I want to take just a second and ask you guys, what benefits have you seen when clients have been in treatment for their substance use?
I'll speak, Dorothy. One of the things that I've noticed is a lot of times it's that relatability aspect of not feeling alone, just having that connection to other people that have experienced some of the same issues and concerns, and maybe, just overall that connectivity to like other supports. And
Yes, absolutely. That's one of the biggest things that begins to decrease stigma, right? Because there is so much self-stigma for people living with substance use disorders, as well as external stigma. So seeing like, oh, someone's been here before, someone has made the changes that I want to make, right? I even saw that in when I worked in short-term residential, is people who were just coming in to treatment saw people who were close to graduating the program, and they were like, man, I want what they have. Like, that is such a good aspect. A few people wrote in the chat feeling more hopeful. Absolutely, that makes a huge difference. That makes a difference with people's kind of willingness to continue engage in that sober support. Emotional intelligence skills, absolutely. A lot of our evidence-based programs are based on that kind of cognitive behavioral therapy or that motivational interviewing, relapse prevention, adding to people's tool belts. When people are able to successfully manage their use, they feel more control over their behaviors. Yeah, empowerment, absolutely. Those are huge things. And yes, patients who had no desire to discontinue their use realized the costs outweigh the benefits. And absolutely, motivational interviewing, those two things really go together. And motivational interviewing is, can't be overstated enough, is kind of meeting clients where they are and engaging in that motivation piece. Also, yes, social and family dynamics, right? And when our families are happy and healthy and thriving, often our communities are happy and healthy and thriving, right? So this is something that, while it might start at the very micro, very personal level, it really has these outreaching effects. Thank you all for sharing. So treatment ultimately is a powerful force for change. This is from the National Institute on Drug Abuse, Nora Volkow. She is a psychiatrist who researches kind of brain changes and dopamine effect changes. And I think this is just so powerful that after 14 months of abstinence, those dopamine levels are able to regenerate, right? So those are really big things that make a difference in people's lives. Abstinence is not the goal for everyone who has substance misuse, but it is for many. And I just think that this is a really powerful graphic that we can begin to share to kind of help people visualize the brain disease model of addiction, which is still the most supported model by our National Institutes of Health. So as I mentioned, I really went back to further my education to begin research based on these barriers that I was seeing for treatment. It was devastating to lose clients to overdose or other drug-related illnesses while they were on the waiting list to come to treatment. And I just I wanted to see how we could maybe streamline this process and maybe capitalize on some of these things, right? So when I was doing my research, which was on kind of treatment access during COVID-19, I really leaned into this model, which is what you see here. So this is the Gelberg-Anderson model for vulnerable populations. So this model is used in a lot of different settings to predict treatment receipt. And there are going to be certain things that encourage treatment receipt and certain things that discourage treatment receipt. So you can see here, these both contain individual and systemic factors, which some that the individual has control over, some they don't. Some it's more related to kind of our treatment centers, our policies, and those sorts of things. So this model was initially used for individuals experiencing homelessness and how they were encouraged to seek primary care. So when you see predisposing factors, these are things that are part of a person, potentially part of a person's identity, right? That might make getting treatment a little bit easier or maybe a little bit more challenging. Enabling factors are, again, things that are going to fall into those certain aspects that make treatment access a little bit easier. So this is what I have used for my research. And so I conducted a systematic review to see what factors in this model really impacted individuals with substance misuse on their treatment. So this systematic review that I conducted in 2022, I had a lot of findings here. So for everything mentioned here was something that did impact whether or not somebody was able to enroll in treatment. Some of these things might be surprising, some might not be so much, right? So 26 to 34-year-olds are the most likely age group to receive treatment, and 18 to 25-year-olds are the least likely age group to receive treatment. So something critical to know here is that 18 to 25-year-olds have the highest rates of substance use in the US. So that's one of those really critical times for us to implement prevention and intervention strategies. White individuals are more likely to use any type of treatment compared to those of minoritized populations. And unfortunately, this is not very surprising due to a lack of cultural knowledge being cited as a reason for not going to treatment. Females overall were more likely to enter treatment for substance abuse than males, and those with greater than a high school education were more likely to attend treatment. Those who are unemployed or employed only part-time were more likely to attend treatment than those who are employed full-time. Those who are married were less likely to attend treatment, and veterans were more likely than non-veterans to engage in a treatment program. When we talk about vulnerable parts of our predisposing factors here, those with substance use disorders as opposed to substance misuse, and those who reported greater problems with their substance use, such as more experiences with overdose or IV use, were more likely to enroll in treatment. And this is related in part due to higher contact with the medical system. Those with higher comorbidities were more likely to enter treatment, so those experiencing more medical or mental health comorbidities. Those with a past history with the legal system were more likely to engage in a treatment program. And those experiencing homelessness were more likely to attend inpatient treatment, but not outpatient treatment, indicating that housing is a real need and a protective factor here. And then so one that did surprise me here is that victimization actually led to higher treatment receipts. So people who had been experienced a history of interpersonal violence were more likely to attend treatment. So are any of those areas things that surprised you based on what you have seen in your practice before? Or any that weren't surprising at all?
So my name is Justin Bishop. I'm a veteran and I'm also a social worker / school counselor.
Oh, great.
And as a veteran, I am surprised to hear that veterans are more likely to seek treatment than non-veterans. In your research, what was what came to that conclusion?
So there is, so this is a systematic review that pulled a bunch of research together. So there is a researcher, their last name is Timko, but they research substance misuse among veterans. And for this article that was pulled, it was talking about VA services. So people had more access to treatment through VA services in the area that we researched, right? So they obviously that can be very different depending on what area that you're in. So that was kind of why they found that veterans were able to attend treatment more frequently than non-veterans.
No, that makes sense. Yeah, thank you.
Yeah. Any others that were surprising or not at all surprising? Yeah, Ashley, I did too. So Ashley said in the chat, I found it fascinating that unemployed individuals were more likely to attend treatment. I wasn't necessarily expecting that, but I think that speaks to our broader systems. When we talk more about some kind of the stigma and things associated with substance use, right? If you're employed full time, you're looking at potentially having to tell your boss, like, I need to go to treatment. I need to do X, Y, or Z. So when I kind of thought it through, it made a little bit of sense, but it still was surprising a little bit. And it makes me wish that we had more access for that. yes, it definitely, Misty said she works in outpatient substance use, and it's definitely a barrier to some. Absolutely. I know one treatment facility that I worked in, their intensive outpatient programming was from like 9 a.m. to noon, which, right, you have to think about that might not be the best time. For one other facility I worked in, did the opposite. Their outpatient was 6 p.m. to 9 p.m. So it really can be based on different things. Dallas, can you elaborate on what you mean by, I think some of that is due to funding options? So like the timing of
Sorry,
outpatient.
I was having a hard time finding my button there for a second, so I apologize. I just noticed probably similar to kind of what you were saying, which was if they were employed, oftentimes they either, it was harder to work around a schedule and some of those components, but also if they weren't employed, they qualified for like Medicaid or other insurances, or even sometimes there was a court interface if the reason that they were getting funding was due to incarceration or probation. And so those were areas where they were allocated funds for that. Whereas once they entered the workforce, some of that's not there.
Right, absolutely. And yes, I agree. And it's like Misty said too, it's difficult to prioritize treatment over employment when you need that money to live. Right. We're going back to that kind of hierarchy of needs. So treatment will likely eventually be a need for many people, but it can absolutely be hard to prioritize that in that key kind of critical phase before what is talked about in recovery is rock bottom, right? So long in recovery models, there has been this, oh, you have to hit rock bottom before you make those changes. Well, that's not really true. We can make those changes and engage in treatment at any point throughout to benefits, but it absolutely can make a can make it hard when you are thinking of all of these little aspects that do make these differences. So what I think is important about some of these areas is they give us kind of those micro areas to target, right? So if we know 18 to 25-year-olds aren't attending treatment, but we do know that they have higher rates of substance misuse, we can take that information to develop prevention and intervention strategies with young adults in that age range, right? If we know that people who are married are less likely to attend treatment, we can add those family components to some of our outreach and our education. So those little, knowing those things, and of course, they're not going to be applicable to every single person, right? People are so unique and have so many different things that make them who they are, but those can be those little key kind of areas that we target. Any other thoughts or questions before we kind of move into the enabling factors? So when we're talking about enabling factors, these are things that can be viewed as some individual factors and some systemic factors. A person doesn't necessarily have control over whether or not a treatment facility accepts their insurance, or how much the program will cost, or if the program accepts grants, or does scholarships, or those sorts of things, right? So some of these are definitely outside of personal realms. So some of these, again, probably won't be too surprising. Some might be. So lack of insurance is often cited as a top reason for not seeking treatment, and individuals without insurance are less likely to engage in services. And states that expanded Medicaid I think from 2012 and beyond, actually have more people that have access to treatment. So where I was from in Tennessee, they chose not to expand Medicaid. So you could only be on Medicaid if you were a child under 18, or a custodial parent to a child under 18, or if you were on Social Security disability. So that is why we had most people coming to our facility under that block grant service. So household income, this one was one that kind of surprised me. Lower income or living in poverty were predictors of treatment receipt. Treatment cost was another top reason for not seeking treatment, and rurality, not being able to access treatment programs, was a reason for not seeking treatment for many individuals. More facilities in an area were associated positively with treatment receipt. And having reliable transportation to treatment, even just one time, was positively associated with continuing treatment. So in additional research that I was very interested in this transportation piece and kind of these physical barriers. So I found that during COVID-19, individuals who had reliable transportation to treatment were actually 3.7 times more likely to engage in treatment and finish a treatment program. So this was even more important in that particular study than the number of treatment centers in someone's area. Then there were some personal factors. So attitudes towards care. Individuals who saw a greater benefit to engaging in treatment were more likely to complete the treatment process. Individuals who had family and children were less likely to attend treatment. And people with a past treatment experience were positively associated with future treatment receipt when they need it. So prior treatment can really demystify kind of the process of that treatment engagement. Now, again, kind of back to our treatment facilities. So treatment center characteristics that were associated with positive treatment receipt and more people being admitted to their programs were having fewer staff positions open, engaging in a patient-centered care program, and providing various services and flexible hours are all positively associated with more attendance. Cultural sensitivity, facilities that engaged in culturally competent practices were more likely to have people attend their services. And then also that stigma piece. So some studies found that substance use stigma was really a barrier to care. And again, it's just thinking of how that kind of external stigma can really become internalized, which is why that normalization that occurs during treatment can be so powerful. So same question as last time. Did any of these surprise you or any not surprise you at all? Yeah, those didn't surprise me at all either, Ashley. Ashley said in the chat, the things on the traditional side did not surprise me at all. It's what I've seen with my work currently. Absolutely. We're going to continue to kind of talk about these. Yeah, really not surprising, right? So this side, if we, even talking about cultural humility and cultural competence, if we're if we're willing to engage in that practice, that sensitive practice, we're going to open ourselves up to more individuals to that treatment seeking. Same thing with patient-centered care, right? So those are just things that we want to consider when we're working with our agencies too, right? Because again, some of these don't necessarily fall on the individual. They don't have control over whether or not our facilities are patient-centered or engaging in culturally competent practice. But those pieces are really important. And then ultimately, and probably very unsurprisingly, perceiving a need for treatment was positively associated with treatment receipt. This will remain consistent when we talk about these barriers and overcoming these barriers coming up. And when we're talking about readiness to change, the hard reality sometimes is that not everyone we meet is going to be ready to attend treatment or ready to engage in treatment or kind of ready to start that process. But that doesn't mean that we can't meet them where they are and potentially overcome a barrier there. So that same survey that tells us all of our great statistics about substance use that are so helpful for us to know and kind of see those trends. They also tell us why people aren't attending treatment, and that comes out every year. So the top institutional barriers, and again, probably not surprising, are cost, knowing where or how to get treatment, and worried about what people would think or say when they get treatment, right? So we're talking about really barriers there that are prevalent in our clients' lives and things that they are experiencing. So overcoming institutional barriers to substance use treatment is a multifaceted approach. It's done through both policy and societal attitudes. And some of these things are really big asks, right? So advocating for significant policy changes and applying for additional funding. When we talk about having many treatment centers in the area, this is what we're talking about, right? That I can't wave a magic wand and pop up a treatment center, though I often wish I could. So when we're talking about, we also want to talk about what our treatment centers are offering. So going back to talking about placing people in treatment, treatment is on a continuum, right? So outpatient isn't going to be the right fit for everyone, neither is inpatient. But if we only have one choice in an area, then we're potentially dealing with some of those larger barriers and potentially not meeting the needs of our clients. And additionally, we have to navigate waiting lists, especially when we have few treatment centers in an area. I could say so many heartbreaking stories about having a waiting list in my program, and it was something that I wished I didn't have. But when you only have 26 residential beds in a facility, and it's mostly grant funded, that's unfortunately going to be a reality for many places. Yes, Jen, that is such a big barrier. It's so hard. It was one of the most heartbreaking things. And there's definitely more than one person that I can remember dying of a drug-related death while waiting to come into treatment. And so that's an area that we too can do more outreach with, right? So at least where I was in practice, it wasn't common to have like check-in groups with people on the waiting list, right? It wasn't common to outreach to people who were waiting to come into treatment. It was just kind of like, well, we'll get you in when your bed's available. Hang in there, bye, right? Which is not the most patient-centered. It's not the most client-centered. And it's not necessarily reminding people that there is support there. So we also want to talk about things like integrated treatment. I know when I did community mental health, we had an integrated healthcare clinic. And it was so great for clients to come one day to the office to get their healthcare, their mental health care, right? If that could all be housed in one building, we are doing a lot to reduce stress. But again, these are things that take money and take space and take capacity that aren't always feasible when we're out in the field trying to navigate those things. But when we do advocate for things like those, when we do apply for grants like things like that integrated healthcare, that reduces the barrier of knowing where to go. Like, I know that I can go to this center and receive everything that I need there, and that can make such a big difference. We also want to continue to advocate for equitable insurance coverage of substance use treatment. If you've worked with an insurance company, you know that treatment for mental health and substance use can often be not as highly covered. I remember having to fight certain, I did our utilization reviews for a period of time. It was an interesting hat to wear as an admissions director, but I wore the hat when I needed to. And I remember having to fight managed care organizations tooth and nail for longer treatment than 5 days in a residential program, right? And having to really advocate for clients in that regard. So some of those were kind of those big barriers, right? Those big things that we need policy change regards, that we need funding for, but there's some things that we can do on a more micro and meso level practice. So education around substance use and misuse begins to decrease the stigma, right? So if substance use really does impact anyone. I'm sure you all have all seen that in your practice. It doesn't discriminate based on race, gender, socioeconomic status, or any of those points of intersectionality. And when we see the person instead of the substance use, instead of the disease, we begin to decrease stigma. And we do this with our practice, but we can do this with our own lives as social workers. So that valuable patient-centered care, that valuable meeting people where they are, can make such a difference. Even including things like including clients in their treatment planning, right? Having their goals set for them, having people shift the language. Right, there are languages that are demeaning that kind of keep people stuck, that have been common language for so long, and we as social workers accept the disease of addiction, right? But that's not what's kind of perpetrated throughout our society. We still very much operate in a moral model, which keeps the shame and the stigma, and it keeps people stuck. And so some of that is kind of changing language, changing those attitudes. Another piece that we can help with is on a small level is creating a knowledge list. So if I'm working with someone without income or ability to pay for treatment, it will be important for me to know where to refer them so that they don't get bogged down by the same kind of those same calling and saying, nope, you have to have this insurance, or nope, this is only for this gender and you don't identify with this gender, right? If we're sending them to places that aren't going to meet their needs, they're running into this over and over, which can be a very frustrating process. So much of treatment is done absolutely on the will and the desire of the person seeking it. We cannot force people into treatment. There are people in my life that I wished that I could have forced into a recovery program, but that's not how it works. It's not how treatment really takes a hold in someone's lives. But we can help them slash some of that time commitment by knowing where to point them. We can't always overcome those waiting lists, but again, we can point people to the self-help and sober support groups while they wait. I actually require all of my students in my substance use class to attend a 12-step meeting or other sober support for a few reasons. It begins to destigmatize and demystify addiction. They see the process of what it's like to search for a meeting in their area, and then they attend the meeting to be able to tell future clients how it feels to sit in a meeting, because we will interact with people who've never been in a treatment program, who have never reached out to that sober support as well. I did this myself when I began working in substance use treatment, and I was very intimidated as a person not in recovery to be in a 12-step meeting and wonder how I could help and how I could offer services to people when I didn't have that personal knowledge of what they had experienced. But what I have found throughout my work is that working with people living with a substance use disorder, a lot of times that brings about a lot of pain. And my pain might not have looked exactly like their pain, but there was always something I could tap into within myself to kind of reach across the bridge and make those connections. And then another key thing is transportation. So knowing that, Medicaid in Utah will transport people to their appointments. Even having transportation to treatment one time can really demystify that process and allow people to see what treatment is like. So Joseph asked in the chat, do I have a referral list of providers? I was actually trying to find this last night from utah.gov, and it was a very confusing process. So I was hoping that we could, at the end here, talk about resources that we're aware of in different areas as well, because I think that's going to be a big piece, is kind of sharing our knowledge with each other there. Any thoughts or questions? I know that I talked a lot without probably taking a breath, but are there any thoughts or questions about overcoming barriers, or anything that you've done in your own practice to kind of overcome these institutional barriers? Yeah, Katie, we'll talk about that in just a second. We're going to talk about some of those personal barriers too. Has anyone had any kind of good experiences or medium experiences with kind of overcoming these institutional barriers? What kind of things would you like to see in your communities to overcome these barriers?
So one thing that I had the pleasure of working in drug court in Idaho, and one of the things that I worked in 2 different counties, and I'm not going to name those counties, but in one county, they held like special events. They did like this little rodeo event, and they had families come, and it was just so accepting, and so like we share this problem. And then the other, it was like that those people kind of construct, you know, where it's very separated from that. And so I think it's important to try to do things that foster community and create connection, and that it's seen as something by involving, you know, more people and more individuals and even families, that it's a way that we can kind of wrap services around them and kind of help destigmatize that. Because you can absolutely have 5 people standing up in a lineup and say, pick out the person with a substance use disorder, and it's impossible to tell. And so it's really important that we all struggle with how we cope and you know, just challenges, and then this, you know, an individual suffering with substance use disorder is no different in that capacity.
Right, absolutely. I think it's kind of the tail end of the, you know, we talk now a lot about how mental health care is healthcare, and I think substance use is still kind of on the tail end of that, where it's harder to get maybe agencies and maybe the community as a whole on board with that kind of concept of like, this is healthcare as well. And I think that is just because of the stigma, right? I think you're absolutely right, Dallas. I think of, you know, everyone that I've worked with, and you could line people up and never know and never guess in those experiences. I think that's a great way, including families, including the community, would be a great way to overcome some of these institutional barriers and begin to share knowledge. So Norman said, grant scholarships, rides, more and better services after rehab, clean living, more pro-social activities, and better agency cooperation. Yeah, that can be one of that last one can be a hard thing, right? If your agencies are so siloed. I always took the mindset when I was admissions director, which was an interesting mindset to take as the admissions director, but because I was responsible for utilizing our grants and having people come in with insurance. It's those not as much fun parts of the job to talk about, but that agency cooperation is a big one, right? Like, we're not in a competition with one another. Like, if somebody goes to another agency, or if I work for one agency and I think that something would be a better fit, I would refer people to that, right? So I knew of specific, especially when I was talking about families with children, we had some specific treatment programs that allowed for children to stay with their parents during treatment. And if I knew that was a big area that someone was wanting and needing, that's where I would refer them to, right? It's not a competition. It's about meeting the needs of the clients. The University of Utah has is it Super Rad program for pregnant moms with opioid addiction to reduce drug effects on babies. Yeah, that's an awesome program. There were several like that in Tennessee, where I came from, that had huge impacts and huge impacts on that's such a vital time, right? When we talk about child development as well, is such a vital time is reducing use or stopping use. But it's also a scary time because if you're risking incarceration or things like that, people might not seek healthcare at the time that they need it most. So absolutely, those programs make such a big difference for us. Any other thoughts before we kind of talk about more of those personal barriers? Great. Thank you all for sharing. So again, back to our national survey on drug use and health. These are the top reasons that people cited for personal barriers to entering treatment in the year 2022. They just came out November 13th. So the data was just published, but the top ones were they felt that they should be able to handle their alcohol or drug use on their own. They weren't ready to start treatment, and they weren't ready to cut back on their alcohol and drug use. So again, that goes really big with that needs piece, right? That do I feel a need for treatment? Do I perceive a need for treatment? That falls in line with that really well. And so Katie had asked advice on how to help clients whose readiness to change isn't high. And that is going to be something that we experience a lot, that even working in treatment working in admissions where people came to talk to me about coming into treatment and wanting to be in treatment, I still encountered sometimes mandated clients that were like, this is stupid. I don't want to be here. But some of those clients I had some of the biggest change with, right? You never want to mark people off just because of their hesitancy to start with. So I'll start with the first one, and kind of those key personal barriers cited include a person feeling like they should be able to cut back or cut down on their use on their own without any intervention. For some people, that's true. For some people, they can do that. For many others, it isn't, right? So when, again, going back to that kind of disease model of addiction that's really well discussed in our kind of treatment circles and our academic circles, the moral model is still perpetrated in the media. I'm sure if you work directly in substance use, when you've talked to people about your jobs and your experience, people will say, well, why can't they just stop? I know I've had that question asked of me so many times. And again, I think it's because we fall on that kind of tail end of like, this is healthcare and treatment is a healthcare, and can really be, it's not as easy as just stopping, right? Most people want to just stop. For many people who are seeking treatment, that is their goal, right? So general education about the disease model and general education about how we can really support people living with substance use disorders and not have that stigma can be so essential. And then we decrease some of that self-stigma. And the other vital barriers that people report are not being ready to start treatment or not ready to cut back on their using or stop using. So motivational interviewing is one of those big things that really assesses that. And it can really explore individuals' goals and why they're feeling that resistance, right? And part of that is exploring what their goals might be. While at the time, and here's kind of where some of those harm reduction methods come in too. So I had a client who was one of my all-time favorite people, but her goal was not to stop using, it was to use more safely. And that was really hard for me because I wanted her goal to be to stop using. I wanted her to say, yes, this has made so much of a difference that I'm never going to go back to my substance of choice. And I am going to, I want, and because it is scary, because with a lot, I'm sure you all know fentanyl is in nearly everything these days. So any substance that's being used illicitly has a risk to it. And so you don't want your clients to go back out and using, but we have to remember that core tenet of self-determination, right? And it's in substance uses when it becomes so hard. So that motivational interviewing explores their goals, explores their desires. But then we also think of harm reduction in its many forms. So in Utah, that includes one harm reduction coalition that includes needle exchange and HIV and hepatitis testing and referral to treatment when people are ready. It can also include providing Narcan to individuals who are using substances or having Narcan readily available. And part of what that does, and part of the process and the purpose of that, is really to show people that I'm meeting you where you are. And so when you are ready, I'm going to be here and we're going to take those processes, right? So, I talk to people who work in harm reduction in places like Seattle and Portland, where it has a more robust programming. And, it's kind of that, we're here for what you need, and when you're ready for treatment, we're going to get you there, right? So overcoming some of those barriers and allowing for that self-determination piece. But it's one of the hardest things. I know when I had a client who was living with an alcohol use disorder and was experiencing homelessness at the time, the day he said he was ready for treatment, I think my car hit 90 miles an hour on the interstate, which back in Tennessee, it's about 65 everywhere you go. And I picked him up instantly and took him, because I was going to take that instant that he was ready. I was going to get him there. I wasn't going to let him change his mind. So sometimes it's things like that, and just being there until the person is ready. Any other thoughts that people have about these kind of overcoming personal barriers and what you've seen in your practice? Yeah, there's a huge fear of social service involvement. Absolutely. Anyone want to share thoughts of what's worked really well for you in the past? Or I also always say comments, questions, concerns, or snide remarks. How do you all honor that kind of self-determination piece in your practice? Can definitely be a hard thing. It can definitely be something that is hard to do. Because sometimes I definitely did want the person to be in treatment more than they wanted it themselves. That definitely wasn't an uncommon thing for me to have experienced. Jen says, I walk clients through a problem-solving activity and have them identify all possible solutions and then the consequences of those actions. Then they choose what they want to do. I make sure that they are okay with the consequences, and then they do what they want. It's hard to remember that we control anyone but ourselves. Yes, that was, and that was a piece with the client that I was telling you all about, that wanted to use substances more safely. Well, she was also on federal probation. So we had to talk through, like, what does safe substance use look like on federal probation if your goal is to not go back to incarceration? And so she was like, well, I don't want to go back to incarceration. I'm like, well, I don't think there's any substance that you can use that would avoid a substance test. So some of that cognitive dissonance challenging, absolutely. Yes, Yeah. And yeah, making that, knowing they're making an informed decision can make a huge difference. Absolutely. And it is hard. It's just hard. Like I said, I hit 80 on the interstate that day because I was like, oh, he's not changing his mind before I get there to get him to treatment. So it's definitely a big thing. So when we talk about what we do as social workers, we can do a few different things, right? So screenings are a key part of identifying people who might be struggling with substance misuse. That screening, brief intervention, referral to treatment can be used in almost any practice, right? And it's often used in primary care settings, in trauma and emergency rooms. But the goal is to provide that kind of early intervention piece for individuals at risk of problematic substance misuse, and kind of assess that motivation for change. Again, that knowledge of resource piece. So knowing our different treatment options, eligibility criteria, assistance with paperwork and applications, knowing what is provided where will make a huge difference. And, kind of advocating for where people can go, and knowing what waiting lists look like, and knowing what insurances are accepted, all of those can make a big difference. Advocacy, we can advocate for our clients to access services and support. This involves negotiating when we're in our treatment agencies, right? Some of our roles will be negotiating which insurances are accepted, and kind of navigating that. And then, of course, counseling and emotional support is a key part of overcoming barriers. It's what we're talking about with that motivational interviewing. It's what we're talking about when we're discussing that self-determination piece. We can build motivation and readiness and be there when the client is ready to make a change, right? When they are ready to engage in those differences in their lives. So when we encourage treatment and reduce substance use, we really support healthy communities. And prevention doesn't always look for substance use, doesn't always look like what we think of when we think of traditional prevention, right? Some of that is providing support for young families, and so that we can prevent adverse childhood experiences. Some of that is fostering those strengths in our communities. I love what Dallas was saying about the drug court that had those programs that really involve family and community, because that is what makes the difference. It doesn't always look like the programs that go into schools and say don't do drugs, right? Because sometimes those aren't the most effective ways of engaging students and of engaging youth, but really it's about having social workers in the schools and those supportive adults to be there to intervene early during trauma. Overcoming stigma is going to be one of those key things that helps us kind of shift the mindset. Portugal decriminalized all substances. And there have been some, interesting effects there. But one of the interesting early effects was that people actually started to view substance use as more like a mental health care, more like, hey, I need to advocate for treatment here. I need to advocate for change here. Language kind of shifted. It was more inclusive language and more acknowledging the person first, which makes such a big difference. And then lastly, meeting people where they are, right? That's what we do as social workers, but also what we have to do when we do that is care for ourselves. It's really authentically care for ourselves too, right? Because it can be really hard when you want something different for a person than they want for themselves. Missy, yeah, it can be a really, really interesting. I don't know a ton about it. I did a little research on Portugal a few years ago, but I know that one of the effects of decriminalization has been kind of that shift. I'm not sure if it's the same for Oregon. Again, it's something I need to do more research on, but it really is interesting kind of how the language at least changed in Portugal, where and I hate this term, but when people were called junkies, that was kind of the norm in Portugal before they shifted to this decriminalization piece. And because it was supported on this more macro level, they started using that person first language, or person, acknowledging that people live with a substance, potentially problematic substance misuse, and those sorts of things. So I thought that was really interesting as well. So any kind of questions or comments? I will stop sharing. I think that's my last slide. If I can find my Zoom bar.
I'm a little curious about just the class that you teach in the social work department.
Yes. So I teach a substance use elective. I base it off a generalist kind of model. So it's not like a practice specifically with substance use. It's more kind of education. So we start by talking about the different substances, right? Kind of the brain disease model of addiction, the critiques to the brain disease model of addiction. So that's kind of our preliminary stuff. Then we talk about policy. We talk a little bit about interventions and assessments. So I do a very small ASAM assessment training to kind of know about level of care and placement. But then we also talk about intersectionality piece. So women and families, minoritized populations, rural versus urban and suburban substance use. And then I also have a section on, or a module on 12-step groups and harm reduction. And I actually interview somebody who is in a 12-step program, who's one of my dear friends, who thankfully allowed me to interview her, and then somebody who worked in harm reduction in Seattle. So I try to make it so it's kind of a generalist model, because again, I just believe that no matter what field of practice you go into, you're likely to encounter somebody living with a substance use disorder at some point. And so I think it's important for us to, as social workers, to kind of have that foundational knowledge.
And do you teach that every year, or is that, sorry to get on this little sidetrack here, but is that something you do every, like once a year for undergrads, graduate?
It's both. It's undergrads and graduate cross-listed in the fall semester so far. So this is my first year, well, my second year at USU. So this is my first, I taught it this summer as an elective, and then I taught it this fall as well.
Cool.
Yeah. Any other thoughts or questions? Anything that you all would like to see offered in your communities about substance use education or prevention? Oh, a magic wand that reduce stigma around MAT. Yes, I wish for that too. So there's a grant that started in 2019, and I'm going to forget the name, but I actually worked at an abstinence only facility that then was required by the federal government to implement an MAT program. And they said, we're not going to give you any guidance on how to implement this. We are just going to tell you you have to, which was really fun. But that was one of the hardest things, is the stigma around MAT, especially in a program that had been abstinence only based. But MAT is such a valuable resource, especially with the way that the opioid crisis is right now. I mean, we're continuing to see over 100,000 people dealing with overdose and overdose deaths every year. And that is too big a number. And MAT is one of the most evidence-based programs for preventing death. Yes, there is still a lot of stigma. There's still a lot of stigma. I mean, it does have potential for abuse, right? And so that was one of the biggest stigma that we had to overcome. But most things have potential for abuse, right? And yeah, it's hard. I wish I had a magic wand. Misty, I'd love to connect and maybe we can talk about some ideas and some ways that we can get some information out. Jen said, you gave me some things to look at into Moab. Support's available on a wait list. Yes, Jen, I'm actually talking with someone at the Moab Regional Healthcare Center. And they're talking about how they do have to, kind of transport people for residential treatment and kind of what that looks like. So I'm hoping to expand on that as well. I would love to touch base with y'all about that. All right. If no one has any other questions or comments, I think that's all I have. Thank you all so much for being here. I love to talk about destigmatizing substance use and overcoming barriers. I know that sometimes the barriers feel insurmountable. So I appreciate all the work that you all are doing. And I thank you so much for being here.
Thank you, Dorothy. That was great. I don't work very often with people experiencing substance abuse or substance use concerns. So this is very informative for myself as somebody who doesn't interact with this population very often. But as we close out our session, I have added the evaluation link to the chat, so you can complete that immediately if that's something you would like to do. But you will also receive it in a follow-up email that I send by the end of the day. I'm also about to put in the link for our upcoming session, which will be happening next month. The session is Mind-Body Bridging, and it's being presented by Derek Tollefson with the iSystem Institute at Utah State University. It's a modality for intervention for mental health. So feel free to check that out. They have a website that you can learn more before attending as well. Before we finish up, just as a reminder, you have to complete that evaluation to receive your continuing education certificate. And then those get sent within about 2 weeks of the session. If you don't see it in about 2 weeks in your email inbox, please reach out. And then lastly, like I said, we have these regularly with our next one in December. But if you would like to stay up to date on when these sessions are occurring, I encourage you to follow the Transforming Communities Institute on social media platforms, as well as USU Social Work. That's where we share our information and provide upcoming opportunities. We are also planning currently our sessions for 2024. So if you have any additional ideas or recommendations for what you would like to see in those sessions, if you complete the evaluation, there is a space for you to put that. Or if you yourself would like to provide a presentation for your fellow providers, we always welcome more folks to participate in that. And we always have requests for a variety of topics. So yours is probably one that people want to know more about. And if you want to set up a time to meet with me to see what that would look like, you can reach out to me at my email address, which is teresa.larson@usu.edu. And I will put that in the chat as well. But if you all have any questions for Dorothy before you leave the meeting, feel free to stay on the call. But otherwise, we thank you all for being here. We thank Dorothy for her time and efforts in preparing this presentation and helping us learn. And hopefully we will see you all again.